Hello and welcome. This is Dr. Peter Nixick, resident at the University of Wisconsin, Division of Plastic and Reconstructive Surgery. We at the Poor Lab would like to thank you for watching our supplemental video on small vessel end-to-end microanastomoses, performed by Dr. Wei-Feng Zhang. This video will cover Lesson 12 of the Microsurgical Training Manual, sub-millimeter end-to-end microanastomoses. Clinical scenarios where operating on small vessels is required include pediatric finger replants and vascularized lymph node transfers. The steps of end-to-end microanastomosis of small vessels are identical to that of larger vessels. However, more dexterity and gentler handling of the tissue is required in order to be successful. With smaller vessels, we recommend trimming only the adventitia that is hanging off the free end of each vessel. The first stitch is thrown in the surgeon's forehand at the 180-degree position. Placing the forceps gently within the vessel will ensure that there is enough counter tension to take your first bite. Getting the first stitch exactly at the 180-degree position is especially important when working with small vessels, as this will ensure that there is optimal suture placement for the rest of the microanastomosis. The second stitch is then placed at the opposite end of the vessel, similar to how the first stitch was placed. Leaving the suture tails long for the first two stitches is helpful so that the surgeon and the assistant can later use these to safely manipulate the vessel. Transitioning to the front wall, needle position is important to minimize the risk of back walling, as this is more common with smaller vessels. Keeping the tip of the needle parallel to the vessel and lifting the first wall of the vessel into the needle is one safe way to accomplish this. Determining the correct number of sutures to complete the anastomosis is something that comes with experience, as the standard 8-suture anastomosis will likely not be required with smaller vessels. As seen in previous videos, the running suture technique can be used to minimize the risk of back walling and maximize efficiency. Leaving the needle within the wall of the vessel in the last stitch of a running suture can act as an anchor point and minimize pull-through while tying. Using the weight of the double opposing Acklin clamps, the vessel is then flipped to the back wall. Using this method, if your first two sutures were placed exactly 180 degrees apart, the back wall should require the same number of sutures as the front wall. Before beginning the back wall portion of the anastomosis, it is appropriate to open the vessel and examine the inside of the front wall anastomosis to ensure that you have not back walled and the vessels are appropriately opposed. As described in previous videos, differential tension when tying your knot can help perfectly oppose the vessel walls and prevent overlapping. In the same manner as the front wall, the back wall is then completed with a running suture. The suture tails are then trimmed and the Acklin clamps are released. Methylene blue dyed saline is then ran through the femoral artery of the blue blood chicken thigh model to examine for leaks and patency. This concludes Lesson 12 of the Microsurgical Training Manual. Thank you for watching.